Hi, this is Dr. Distano. In this brief presentation, we will review with you our blueprint to pain relief, which is essentially our three-tiered approach to patient management. And we will also give you an outline about our process and how we exactly manage and categorize patients so they have the best outcome possible. So the first thing that we do when we meet with a patient in our office is to ensure their safety, to make sure that the condition or the signs and symptoms that they are presenting to us with is something that we can actually help them with and that they may not need to be referred immediately to another healthcare provider. These signs and symptoms are what we call red flags, and the standard of care demands that we rule out red flags. This can be conditions such as cancer, infections, fractures, or pain that is being referred from the organs, such as the lungs, pancreas, or gallbladder. Many times, pain from organs are referred to the spine and present as back pain or neck pain. So, in these instances, if red flags are present, we may need to immediately refer the patient, for example, to the emergency department or to a surgeon for immediate surgery. Again, this is rare and happens less than 5% of the time. Um, and it may also indicate to us that before we could safely treat you, we may need further investigation via X-ray, MRI, or lab workup. Once the red flags are ruled out, the next thing we determine is, do we need to work with another provider to optimally manage your condition? And that could be referral to a pain management physician for pain medicine or injections, or to a neurologist, orthopedist, or even psychologist in some instances. Once we rule out red flags and we determine if we need co-management, the next thing we do, and is very important again what the standard of care dictates, is that we assess for yellow flags. Now, yellow flags are different than red flags in the sense that they don't indicate immediate referral, but yellow flags indicate that we may need to proceed with caution and somewhat change our care plan if these yellow flags are present. So, in a simple sense, yellow flags are major pain influencers. Now, they could add fuel to the fire or be a breeding ground for pain. So, if these yellow flags, which we're going to talk about, are present, they can magnify your symptoms or make your pain feel worse, or even be factors that can make you more susceptible to an onset of pain. And these yellow flags actually help to determine your outcome or the length of treatment that you may require. The more yellow flags that are present, a lot of times the more complex the case and the longer treatment is required. So the major yellow flags that the research has identified are listed here on the screen. And any of these factors could actually be playing a role in increasing the amount of sensitivity or the amount of pain that you feel. And they may be underlying situations or factors which can be contributing to a delayed recovery and may be playing a role in chronic pain. So we try to identify these factors, and quite possibly we may have to intervene or provide strategies to address these factors. So depression and anxiety often go hand in hand with pain, or pain could lead to depression and anxiety, or an anxiety disorder or a case of depression could be presenting physically as pain. So those are pretty easy to see, the relation, and to understand what those two are. The next three or four may be a little more difficult to understand, or you may not be familiar with, but essentially catastrophizing is seeing your pain as a catastrophe or always having catastrophic thinking or thoughts. For example, if you feel pain, you may think the pain's never going to go away, or I may end up in a wheelchair, or my pain must mean I'm damaging something, or I have cancer. Fear avoidance is essentially avoiding activities or movements because you're afraid to provoke pain or make pain worse or afraid to damage something. Helplessness is referred to in the research as self-efficacy and passive coping, which essentially means you feel helpless in your ability to control the pain. You're not really sure about strategies that lead to pain relief, which leads you to seek pain relief from outside sources other than um, strategies that you can control with certain stretches, exercise, meditation, etc. So having low self-efficacy or feeling helpless leads you to rely on medications, injections, maybe excessive chiropractic or physical therapy treatments or massages because you don't know how to help yourself or you haven't been shown how to help yourself. And then finally, our beliefs about pain. If we believe that every time we feel pain, we're hurting or damaging something, or we believe we're never going to get better, um, that is a yellow flag, and that could play a role in the development of pain and maybe a barrier to the resolution of pain. And we know lifestyle can play a significant role in pain relief. And in fact, many of the same lifestyle factors that contribute to chronic illness and disease, such as poor diet, poor general health, high stress levels, low levels of physical activity, and poor sleep quality, they actually can play a role in increasing your pain sensitivity. So if you're not sleeping well, you're not moving, you have high stress, poor health, and bad nutrition, that can make your pain magnified, or it could be a breeding ground to set you up for a painful episode. So it's real important that we identify these yellow flags because it gives us a wide overview of you as the patient so we can take in a holistic approach, that we're not just treating you as the body part that's hurting, or we're not just treating you as an x-ray or MRI, but we're understanding your emotions, your thoughts, your beliefs, and your lifestyle. Because again, all of those yellow flags or issues are possible areas where we can intervene to give you pain relief or to actually take control of your pain. So, a key to understanding how these yellow flags influence our pain levels, or how lack of sleep and high stress levels or fearful thoughts could play a role in heightening our pain experience or increasing our pain sensitivity, lies in understanding where pain comes from. Now, pain is not actually produced by the body, it's actually produced by the brain. So even though we feel pain in body parts, that's the area of our brain associated with the body parts that's producing the pain. So if our back hurts, the area of our back in our brain lights up and lets us know the back hurts. So pain doesn't come from the body, but the brain does rely on what's going on with the body as part of its decision to generate pain or not. So it does matter what's going on with the joints and the discs to a degree. But what the research shows, our thoughts, our beliefs, our emotions, and our lifestyle factors have more of an influence on pain levels than X-ray and MRI. And we know through research that many findings on X-ray or MRI that we used to think were really significant, like disc degeneration or disc bulges, are most of the time part of normal age-related changes. And what the research shows is most of the time have little to no correlation with pain, because we could find a huge portion of people that are not in pain yet have the same MRI findings as someone in pain. The difference lies in different amount of emotional factors such as depression, anxiety, different thoughts, beliefs, and behaviors about pain, and different lifestyle factors such as sleep, stress, and diet, like we talked about. And that is why our interventions seek to try to change the way the brain processes and produces pain, rather than trying to explain or tell someone that we're trying to fix their arthritis or put their spine back in alignment. Um, the latter just is not current with what we know about the way modern pain science works, and how the body and brain works. So the question is, how do our interventions work? Why do our interventions work? What are we trying to do with manual therapy and exercise and patient education? Are we trying to put bones back in alignment? Are we trying to help arthritis? Are we trying to affect a rotator cuff tear or a disc herniation? The answer in short is our interventions work because it stimulates the body's natural pain relieving system. So we have all heard about the feel-good chemicals, endorphins and enkephalins. That's the chemicals released when we exercise or when we're having fun and having a good time. These are powerful pain relieving chemicals that our body generates with the right stimulus. These are also the same chemicals that are affected when we're taking pain medication. And we know we could take pain medication and feel significantly better, or we could be in pain and someone massages us briefly and we feel better, or we could be in pain and do certain stretches or exercises and we feel relief. Well, we didn't change someone's alignment, we didn't change their arthritis, we didn't change any structure within a 5 or 10 minute massage session or chiropractic treatment or walk on the treadmill, but yet we may feel better. And this is the reason. These interventions stimulate natural pain relief in the body. So our target is to change function, change the chemistry of the brain and the brain's pain processing center. We're not trying to affect anatomy or structure because we can't do that. Only surgery can. And the research shows that simple explanation and talking and patient education is one way to open up that pain medicine cabinet. And that's why we are so heavily grounded in patient education. Also, one of the best ways that the research shows is through exercise. So patient education and exercise are long-term strategies and are the best option for long-term change and long-term pain relief. The manual therapy component, which everybody loves, it's the feel-good touch, massage, stretching, is a short-term option. That will never give you long-term pain relief and is never a long-term standalone strategy. When we do implement manual therapy, and again, it's not on every case for every patient, but when we do implement it, it's an adjunct or a supplement to our patient education program and exercise and rehabilitation program. So after we rule out red flags, make a determination if we need to refer the patient for co-management with another medical practitioner, and we assess for these yellow flags. We try to come up with a prognosis. Now, a prognosis is the expected outcome or the expected duration that the patient can anticipate that they will be under our care. And that not only depends on the amount of yellow flags that the patient presents with, but also different things such as the severity of pain the patient presents with, multiple sites of pain such as widespread pain in the neck, back, arms, and legs, any neurological findings as numbness, tingling, weakness. We take all of these factors into consideration when we make the prognosis. And the good thing is, most cases that we deal with of back pain, neck pain, and joint pain have a really good prognosis. People could expect to feel better relatively quickly, even though the pain may not be resolved completely quickly. Within 4 to 8 visits, either the pain is resolved or it's on the path of resolution that can be managed with simple advice and home exercises that the patient can do on their own that they don't have to rely on us for. The caveat to that is most cases of musculoskeletal pain, back pain, neck pain, or joint pain has a high recurrence rate. And it is our hope that with our extensive patient education program and our home exercise program that we give patients, that we could reduce the rate of recurrence. And if you do have a flare-up of pain or an exacerbation, that the exacerbation won't last nearly as long as it might have if you didn't have the self-help strategies and the home exercise program. But the key is to stick with these exercises and the advice even after you're out of pain. Now, a small percentage will require more than 8 visits, closer to the lines of 12, 24, and even 36 visits. But again, those are complex cases where the pain is severe, it's lasted long, and there's multiple yellow flags or barriers to recovery. And then the other type of case that would require ongoing treatment are post-surgical cases such as a joint replacement or rotator cuff repair that usually needs 3 to 4 months of rehabilitation minimum. But again, on average, most cases get better and are managed within 2 to 4 weeks. So after we assess your case and we generate a prognosis or an expected outcome and an estimated amount of time that you may have to treat with us, that is when we begin to implement our 3-tiered approach of patient education, exercise and physical rehabilitation, and manual therapy. And the evidence has shown when you combine these three strategies, it is highly effective at managing pain without the use of medication, injections, and surgery. So how do you get the quickest relief or the best results possible? The first thing is utilize our educational resources. We have a wide variety of educational resources that we share with our patients, and they're all designed to feed into your customized blueprint to pain relief. So really all you have to do is follow your customized blueprint to pain relief and all the advice given within that. And try your best to keep all appointments as planned. We understand sometimes life gets in the way, but each chiropractic and rehab visit builds on the previous visit and is strategically designed to do so. And even after you are out of your episode of pain or your episode of pain is managed, follow through with these recommendations to reduce the risk of recurrence or re-injury. And finally, we want to thank you for choosing our office, putting your trust in our staff, and we look forward to joining you on your pain relief journey. Pain relief awaits you.